And Steph, would you make the folks I've added as panelists co-hosts as well? Just
They are both co-hosts now. I'm sorry, I didn't realize you added more. Sorry.
oh, no worries, no worries. I think just one more. Dr. Spencer might want to say hi.
Hi, how are you?
Heavy.
Very much looking forward to your talk.
I'm really excited to give it.
Excellent. Well, welcome to virtual St. Louis.
I know. I was joking. I was on a faculty meeting just before this. I said, I have to sign off early because I'm going to St. Louis to give it my pronouns in 20 minutes. So
All right, Dr. Liebschutz, you ready to get going?
I'm absolutely ready.
All right. I think everything's in order here. Let me go ahead and get started. Good morning, everybody. I'm John Hickman, one of the chief residents of internal medicine. It is my pleasure, as always, to welcome you back to Grand Rounds at the Department of Medicine of Washington University School of Medicine. On behalf of our chair, Dr. Frazier, Drs. Costco, Spencer, and myself, we're just so excited for our talk today. As a reminder, please head over to the Department of Medicine website to check out our YouTube channel for some of the talks you've missed in the past. And today, as always, I will be helping to facilitate our Q&A with our speaker at the end, provided we got time. So please send any questions or comments through the chat or the Q&A as we go. We are really pleased to be joined this morning by Dr. Jane Liebschutz from UPMC. Dr. Liebschutz started her training at Harvard Medical School, followed by an MPH residency and fellowship at Boston University. She is currently the Chief of General Internal Medicine at UPMC, the Endowed Chair of Translational Medicine and Research, and the Director for the Center for Research on Healthcare. She is, it sounds like, a primary care doctor at heart who specializes in addiction medicine with research supported by the NIH's National Institute on Drug Abuse and the Robert Wood Johnson Foundation, just to name a few. She is a leader in addiction medicine with current R01 funding to study implementing opioid risk reduction strategies in primary care. And like I said, we are so excited to have her share her expertise on the dual crises of COVID and substance use disorder. Dr. Liebschutz, thank you so much for being here today.
Thank you for that nice introduction. And I should say that I actually am a primary care, not just at heart. I do practice primary care and addiction medicine. And let's get started. So I have no commercial disclosures. 3 main learning objectives today. First, we're going to define the 3 waves of the current opioid epidemic. This may be review for some of you, but I feel like it's good to make sure we're all on the same wavelength. And again, a review for many of you of evidence-based treatment of opioid use disorder. And then I'll spend the last part of our talk really talking about the interactions between opioid use disorder, substance use disorder, and the COVID epidemics. So about 200 years ago, a pharmacist in Germany named Friedrich Wilhelm Adam Serturner discovered and isolated morphine, which he named that for the Morpheus, the god of sleep and dreams. And he tested it. It's from a poppy seed plant, and he tested on his apprentices to find the right dose for pain relief and the lack of sleepiness. And that became 15 milligrams, which is sort of the standard dose of morphine that we use today. So I'm going to use Michael S. Through the ages to see how he might be interacting with opioids. And Michael S. in 1864 would have been a Civil War veteran or a soldier who may have had a battle injury, and he would have received morphine. Of note, the hypodermic needle was developed in 1853 specifically for administration of morphine. Fast forward to 1899, Michael S. He might have had a chronic cough from industrial exposure, and he might have been prescribed diacetylmorphine, also known as heroin, from Bayer, which was marketed as alternative, less addicting than morphine, and cheap. And in fast forward to the early part of the 1900s, there was major issues with opioids. And this is a quote from the cabinet level opium commissioner of the United States, which was, the quote is, "Of all the nations in the world, the United States consumes most habit-forming drugs per capita. Opium, the most pernicious drug known to humanity, is surrounded in this country with far fewer safeguards than any other nation in Europe fences it with. China now guards it with much more greater care than we do." And so that crisis in the early 1910s led to the Harrison Act of 1914, which still impacts our prescribing and regulations on opioids. And the goal of that was to combat the addictive properties of what were then medicinal opioids, heroin, morphine, codeine, to regulate non-medical opioid use, made possession without a prescription illegal, and you had a special stamp tax or tax stamp that practitioners could use to dispense the opioids for medicinal reasons, and it still has impact today, and I'll come back to that later. Just a reminder, I don't want any PTSD from organic chemistry flashbacks, but just a reminder, there are different sort of groupings of opioids. So you've got the opioids that are morphine, which directly came from the poppy plant, and then semi-synthetic derivatives, which all kind of start from morphine and have different chemical compounds to make them what they are today. All of these can metabolize back to morphine and to have a urine drug screen positive for opiate. Then you've got a semi-synthetic on the far right, which is also from the poppy plant, but is not from the morphine. It's from thebaine, which is another compound from the poppy plant, and that is buprenorphine. And that does not metabolize back to opiate. And then you have synthetics, and that includes things like methadone, meperidine, or fentanyl. And these never derived and never had anything to do with the poppy seed plant, but are chemically related, and they never metabolize back to opiate. And you have to test for them specifically if you want to know if somebody was using them. So fast forward to the 1960s and 70s, heroin was most prevalent in a couple of communities, largely minority inner city communities, also in groups of Vietnam vets. Methadone was approved in 1972 as a method for treating, but because of the Harrison Act, it was made as an exception to the Harrison Act, and there were very strict regulations on dispensing, largely putting people in methadone clinics in, not in my backyard, in really undesirable neighborhoods, highly stigmatized. And this is a picture of a methadone clinic you can see under a highway overpass. So who is Michael S. in 1974? He is a Vietnam vet. He was exposed to heroin and other drugs during his deployment in Vietnam, and he is treated with methadone. So then what comes next is in the 70s and 1980s, there was real movement around undertreatment of pain. And I think this was very legitimate, that there was not as much attention paid to the needs of patients particularly with cancer and other painful conditions. So there was sort of a movement to treat with narcotic analgesics. There was this little letter to the editor in the New England Journal I think it was in 1980. And it was, you can see it's probably like 5 or 6 sentences. And these two folks did a surveillance of files of almost 40,000 hospitalized patients, and of whom 12,000 had narcotics, and they had 4 cases of addiction in those patients, and said use of pain meds is not related to addiction. And this is quoted year after year after year after year until no one knew what the original piece was. But I have to show you that that was used as justification for really a massive increase in opioid prescribing. And you can see in 1996, OxyContin, as we all know, was marketed aggressively by Purdue. And in this chart, which you can see goes from 1965 to 2001, that dotted, those little black dots, sort of starting in the 90s, all of a sudden started to increase in how it was. Maybe I can show on here that I don't know if this pointer you can see, but how it was sort of massively thousands of new users in the 1990s. Sedatives also increased, but not to the same degree as opioids. So who is Michael S. in 1997? He has somebody who has chronic back pain from a construction accident. He is now disabled, and he is prescribed OxyContin to help with pain. So this is a graph that shows the parallel rise in opioid prescriptions, addiction, and overdose. So the red dotted line is the opioid pain reliever sales, kilograms per 10,000 individuals. And you can see in 1999, that number was a little bit under 2. And when you get to 10 years later, it's about 7, so more than 3 times. And the parallel in opioid pain reliever overdose deaths increases, the admissions for substance use treatment increases, and the neonatal abstinence or neonatal opioid withdrawal syndrome and NICU admissions also markedly increase in parallel. But, so one other note is there's a concept of MED, which is morphine equivalent doses. And there was a sense in the data, in large data sets, there was a little bit of an inflection point at 100 MED, which really was a mark for increase of fatal overdose risk. And a lot of things that follow from that were related to that 100 MED. Just a note, there were pill mills. These are clinics where a small number of physicians prescribed an outside number of pills. And this is just one in Florida that was done. And those are largely shut down now, but they were really prevalent in the 2000s and early 2010s. Let's talk about the second wave, which is heroin. And you can see in this graph here on the left, the blue line is number of overdose deaths per 100,000 populations. And you can see the number of deaths from prescription opioids climbed through the 2000s, started to level off around 2010. And at the same time, heroin started to pick up. And there is some narrative out in public that it was because people turned from prescription opioids to heroin, but the data really doesn't bear that out. And if you hear that, you might want to put your skepticism hat on it, because what really happened at the same time was we had some Mexican cartels that were really smart, and they started marketing directly to suburban white customers. It wasn't necessarily folks who use drugs who were dealing them, and the opioid prescriptions were leveling off, but the heroin was already well on the rise before that happened. And so now we've got the double whammy of both opioid prescriptions, pain relievers, and heroin. And what happened was heroin really rose. If you see in this graph in 2002, in the National Survey on Drug Use, there were about 400,000 folks who said they tried heroin the past year. And you fast forward to the mid 20 teens and you get almost 1 million And that kind of leveled off. And the heroin deaths, because obviously heroin is much more potent than other pain relievers, that the number of deaths around 2000, in 2002 was about 2,000. And then in 2017, it was 8 times that much, over 15,000. So, really a marked increase in deaths from heroin. So in 2010, who is Michael S? He was an unemployed coal miner. When his OxyContin supply had been cut off, he started buying heroin, injecting it 3 to 4 times daily. He's had a couple of overdoses. His girlfriend works as a nurse. He watches his kids when the girlfriend works. So this is really also demonstrating the large impact on families in rural areas, on the heroin use epidemic. And then after that, not too many years later, in about 2014, we have fentanyl. Fentanyl is 50 times more potent than heroin. It's manufactured in China and elsewhere. It's very cheap to manufacture. You can have, it's much easier to transport, lower quantities with higher potency. And it started to get mixed with heroin and other drugs to increase the high. Carfentanil is even 10,000 times more potent than morphine. And so some of these fentanyl derivatives, and carfentanil is really like elephant tranquilizer. So you've got sort of much higher rates of death from these potent opioids. So Michael S. in 2016, he had multiple non-fatal overdoses. There were no treatment slots in his rural county, and he died of a fentanyl overdose. And I'll come back in a little bit when I talk about the combination of COVID and opioids, but the last year for official certified data that we have from the CDC showed in 2019, there were 70,000 drug overdose deaths, and of which almost 50,000 are opioid. And I got data from Missouri, which were 14,000 opioid deaths, or 26.9 people per 100,000 population, which is sort of high, up in the higher range in the country. And in the graph on the right, what you see is that a kind of light blue line that's shooting for the sky. You can see, where does that take off? That line takes off around 2014, and that is synthetic opioids other than methadone. And these are overdose deaths from 1999 to 2017. The next line is heroin. You can see that one took off at 2010. And then the kind of green, the next line down are the prescription opioid pain relievers. And that is, sort of has leveled off, although it's still an important contribution to death. And then you've got cocaine, methamphetamine, which is also on the rise. And if I extended this out, you would start to see methamphetamine go up pretty steeply. All right, so that's kind of for epi and setting the stage. Let's move now to opioid use disorder. And hopefully this is a reminder for some of you, or a reinforcement of something you may have learned before. But let's first just acknowledge that addiction is a brain disease. Drugs hijack the brain reward circuit. They put out dopamine, and then we upregulate the neurotransmitters, and we develop tolerance and withdrawal with repeated use. It's also a learned behavior and habit. So not only do you get some of the withdrawal and some of the brain symbols, but we also, it's a repeated behavior. And so in order to treat it, we need both to work on the brain circuits, but we also need to reprogram our behaviors. Just a reminder, a DSM-V criteria for opioid use disorder: using in larger amounts or over a longer period than intended, unsuccessful efforts to cut down, or with persistent use, a great deal of time spent getting, using, or recovering from use, craving or a strong desire to use, recurrent use resulting in failure to fulfill major obligations at work, school, or home, continued use despite social or interpersonal problems caused by use. And then social, work, or recreational activities given up or reduced, use in situations which is physically hazardous, such as driving or operating machinery, or potentially, watching children or other areas where it's responsible. People who continue to use it despite physical consequences or psychological harm. And then classic withdrawal could be either classic withdrawal, or some folks don't even ever let themselves go into withdrawal, and they take opioids to prevent withdrawal from happening. And then tolerance, the need for increased amount to achieve the same effect or decreased effect in the same amount. I want to make sure that people are not using language that's outdated. I often see people say opioid abuse, and that really is not a clinical diagnosis. It's really opioid use disorder, mild, moderate, or severe. And so that should be the terminology. And 2 to 3 of these symptoms include mild, 4 to 5 are moderate, and 6 or more severe. And there is just one exception to this, which is that if you are prescribed opioid pain relievers, and you may develop tolerance and withdrawal, but it doesn't mean you have an opioid use disorder. It means you just have physical dependence. So if you are prescribed an opioid pain reliever and you have tolerance and withdrawal, you need an additional symptom on the criteria to qualify for opioid use disorder. And then if that's the case, then withdrawal and tolerance are added in and do add into that. But you don't get it just for those two alone. All right, so types of treatment. I'm going to really focus on medications, and just a word that behavioral therapies and self-help groups may be useful, but they're not really evidence-based to improve opioid overdose or mortality. And I'm not going to really focus more. If you guys have questions, I can talk more about that in question and answer. But when we talk about medication treatments, there's sort of 3 classifications. There's full agonists, there's partial agonists, and there's antagonists. And I'm not going to be talking about morphine, but that is, it is approved in Canada and in Europe for addiction specialists to prescribe morphine. And there's also underfoot in some more forward-thinking countries about actually heroin itself being used as a treatment, but that's not relevant in the United States, so I'm not going to talk more about it. So let me talk about the 3 medications approved in the United States. They are buprenorphine, methadone, and naltrexone, but let's just look at withdrawal symptom severity. So heroin gives an extreme severe withdrawal that peaks at about 3 days, 3 to 4 days, depending on individual's metabolism, and then is done. Buprenorphine gives a less severe withdrawal. It comes on a little bit later and lasts longer than heroin. And then methadone gives a more milder withdrawal, but it can last for quite a long time. And many folks who've been on high doses of methadone will talk about experiencing withdrawal 6, 8, 12, 6 months after cessation. And it's likely that that is happening. So a lot of people are afraid to get on methadone because they're afraid of the withdrawal, or same with buprenorphine. So what is the clinical setting that these are licensed to be prescribed? So methadone, as I mentioned earlier, was licensed in the 1970s, and many restrictive rules around it. And they're both federal rules and state rules, and they can only be dispensed in a federally licensed facility. And the individual has to come daily for observed dosing with liquid methadone, very tightly prescribed regulations. I'm going to come back to this when we talk about what happened during the beginning of the COVID pandemic. Buprenorphine can be given in any outpatient setting by a prescriber who has a DEA waiver for this, and up to a 30-day supply can be dispensed. If you are not waivered and you have a DEA license, you can go on and I should have put a link in the chat. Maybe somebody who is on their website can do that and put it in the chat, and we'll give it for people. Right now, you can be waivered for up to 30 patients to do this without any additional education. And that also was changed recently. It used to be, and if you need, and currently is, if you want to prescribe for more than 30 patients, that you need to go through an 8-hour waiver training, which are free, and there are multiple can be found, and I can send information if anybody's interested. But since the pandemic, it's been changed. And also nurse practitioners and physician's assistants can also become waivered now in the last few years for that, and they need longer training for that. And then naltrexone is a pure antagonist, and any licensed prescriber, you don't need any special training or any special licensing. It comes in 2 forms, which is an oral, which is approved both for alcohol use disorder and opioid use disorder, and an injectable, which can last 4 weeks. There's another injectable coming on the market soon, which is a 1-week or a 4-week injectable as well. And I'm gonna now, I already talked about this, and this. So one other thing, even if you are not waivered to prescribe, and even if you do not have a full DEA license, you're a resident, you can prescribe methadone and buprenorphine in the hospital if opioid use disorder is complicating inpatient treatment. And generally those doses are anywhere between 20 and 40 milligrams a day, and buprenorphine 2 to 16 milligrams a day. Just a word about buprenorphine, it's a partial agonist. It has a high affinity to the mu opioid receptor, and if there is another full agonist on board and buprenorphine is given, it may bump off the other agonist, and because it's just a partial agonist, it may cause the individual to experience withdrawal. So to prescribe this, you need to have the individual opioid free. The other option, and again, I'm not going into detail because of time, there are new low dose or micro induction protocols for patients who are on opioids. You can use the Butrans patch to get them started to occupy some of the mu opioid receptors, and then can introduce Suboxone or buprenorphine without causing withdrawal. And that really is now standard of practice for those of us who do addiction medicine in the hospital. So why am I so focused on these 2 medications, buprenorphine and methadone? Well, they are life-saving. This is a meta-analysis that was published a few years ago in the British Medical Journal. And I know there's a lot of numbers here, so I'm on the left-hand box, I'm summarizing. For methadone, all-cause mortality rates per 1,000. If somebody is on methadone, that would be 11.3 versus somebody who has opioid use disorder who is not on methadone, 36.1. I mean, this is far and exceeds any treatment we have for cardiac disease or pretty much, anything. Maybe anticoagulation for pulmonary embolus would be similar, but this is hugely effective medication, and this should be standard of care for all our patients that we prescribe. Buprenorphine is cut down from 4.3 versus 9.5 per mortality rate per 1,000 individuals. So both life-saving medications. This is standard of care. We should be getting all our patients on this and trying to keep them on it. This is another slide. This is the meta-analysis I just showed. We're looking at randomized controlled trials. This is actually real-world data that my colleague and I and others published a few years ago in Annals of Internal Medicine. And this looked at 17,000 individuals who had had a non-fatal overdose and followed them to see what happened when they were on medication or off medication, and compared to those who were not on medication. Buprenorphine and methadone cut the future rate of fatal overdose by 2/3. So the hazard ratio was 0.3. Naltrexone did not have statistical significance, and part of the reason for naltrexone is that people were not on it for very long. They would get 1 dose and would not go back for a repeat dose. So that's another reason why I'm really bullish on buprenorphine and methadone So now I've wrapped up the first and second part of my talks. And now I want to spend the rest of the time really thinking about the dual epidemics of opioid use disorder and COVID-19, and sort of 4 areas I want to cover, which is the increased risk for infection among individuals with opioid use disorder and substance use disorder, worse COVID outcomes, worse opioid outcomes, and then expanded treatment access. So first, I want to show you that a number of studies, particularly looking at large data sets, looked at COVID-19 risk in individuals who had diagnoses with substance use disorders. So this was a study of 73 million patients, of whom about 7 million had a diagnosis with substance use disorder, and of whom about 10% of those had been recently diagnosed with that. And there were about 12,000 COVID diagnoses. And so what they looked at, I didn't do this study, was what risk did having a diagnosis of substance use disorder confer on risk of getting a COVID-19 diagnosis. And what you see in the top line here is that the adjusted odds ratio is about 8 for any substance use disorder, and opioid use disorder had a adjusted odds ratio of about 10. So really 10 times as likely to be diagnosed with a COVID-19 infection. And this was done in the first few months of the pandemic. And we have other data suggest that that hasn't changed. This was a study that was done recently, was put online ahead of print in the last month. And this looked at breakthrough infections of individuals who were fully vaccinated, who also had a diagnosis. Some had diagnosed substance use disorder and some did not. And this is from this data set called TriNet-X, which is de-identified electronic health records among 63 healthcare organizations. So there was 579,000 patients who had been fully vaccinated. And among those who also had a substance use disorder diagnosis, the level of breakthrough infections was 6.8 to 7.8, depending on the specific substance that was diagnosed. And those who did not have a substance use disorder, it was 3.6. And controlling for age, gender, and ethnicity, substance use disorder remained a predictor of breakthrough. However, and this is really the key part of this study, that when you then went back and you matched the patients for lifetime comorbidities and socioeconomic status, the increased risk for substance use disorder really disappeared, apart from cannabis use disorder, which still remained at increased risk, but a much lower hazard ratio. So I think the key here is that this points to why our patients with substance use disorder are at increased risk, since really for their comorbidities and their socioeconomic status and social determinants of health. This slide is a little bit complicated, but I want you to first look at I will just start with the orange bars. So those are Caucasians, and this would be the mortality rate among Caucasians with substance use disorder. So the one on the left is those who had just COVID-19, but not a substance use disorder. And you can see the death rate was about 6%. And these are hospitalized patients. Among the middle group was individuals who were had a lifetime diagnosis in their medical record of substance use disorder. And this was, and you see the hazard rate, or the rate went up to about 8% mortality. And then if they had a past year substance use disorder in their record, the rate went up to almost 10% mortality. So you can see that. What's interesting is in the blue bars is the African American. And again, the same groups. On the left is those with COVID-19, the middle with COVID-19 and a lifetime history of substance use, and the right would be a recent substance use. And a couple things. One is you see a increase with both past and recent substance use diagnoses, but you also see a marked difference between African American and Caucasian in this sample. And so I think that really further emphasizes the social determinants of health, socioeconomic status, and the racial disparities that we have seen in the epidemic exacerbated by substance use. So a little bit complicated, but I think it's important data that you should be aware of. And I'm sure St. Louis populations, you're seeing exactly the same thing. So I talked a little bit already, why the increase of death rate. So patients with substance use disorder have a much higher prevalence of chronic diseases, such as, kidney, liver, lung, cardiovascular. There's often obesity and cancer and type 2 diabetes that goes along with substance use. And then, of course, the health behavior of smoking really, exacerbates this, compounds this. And then this slide, I'm not a basic scientist, so I'm not sure I understand everything on this slide, but this is sort of a schematic of why there might be this sense of pathogenesis and pathology of COVID-19. So SARS-CoV-2 infects the vascular endothelial cells through the surface expressed ACE2 receptor, and then internalization of the virus causes the endothelial cell death, reactive oxidative species, and then pro-inflammatory cytokines. And so then you get this, inflammation, a cytokine storm, and then this leads to vascular leakage and coagulation. So a number of substances of abuse exert the same effects at the brain endothelial cells, though they disrupt the blood-brain barrier, and they may allow viral infection in the CNS. So this is really why might we see this? And this is looking at pathology. And I think probably in the next year, we'll understand more as we understand more about the virus. So we've talked about why individuals with substance use are increased risk for infection and worse outcomes. Let's talk about what's happened in the last year and a half with opioid use disorder outcomes. And actually just yesterday, in the New York Times on the bottom left, this was the headline: opioid overdose deaths reached record high as pandemic spread. And this data just came. I actually had a slightly different graph from a few weeks ago, but this came out yesterday. And what you see here, this graph is the number of drug overdose deaths in the US through April 2021. So I showed you earlier that the latest official counts we have are 2019. And why is that? It's because there's provisional opioid overdose or drug overdose deaths, and then there's official, and it often takes many months or a year for the toxicology to come back and deaths to be attributed to drug overdose, and a lot of adjudication. So we're often like 2 years behind in where we are with the official numbers. But in any case, if you look here in January of 2015, there were about 50,000 drug overdose deaths. If you fast forward 6 years to the 12-month period ending April 2021, the official account was about 98,000, but the predicted number after the adjudication will be over 100,000. And this is unbelievably record-breaking. And you can see, twice as many overdose deaths in a 6-year period. And this is data from Missouri. And this is also through April. And you can see the same thing here, from a little bit over 1,000 to almost 2,000 deaths in a 6-year period of time. And really, really incredible. This chart here, this was what I had earlier from March to March, but I just sort of left it up because I didn't change it. But essentially from March 2020 to March 2021, we had a 31% increase in drug overdose deaths by jurisdiction, and really, really incredible. And so, I mean, this really is a huge epidemic, and I'm sure many are not even counted. Motor vehicle crashes may be a true drug overdose. We don't know. Suicides. This is the next slide is just further data showing not just overdose, but drug use itself. And this is a comparison of urine drug screens from Quest Diagnostics. And the green is January to March 14th, 2020 versus March 14th to May 16th. So same time period, but just, right before and right after the COVID epidemic was declared. And you can see here the fentanyl numbers, the positivity rate went from 4.3 to 5.8. The heroin went from 0.9 to 1.3. The opiates went from 6.1 to 6.7. And whereas gabapentin went down, benzodiazepines went down, marijuana was slightly up. So just sort of showing you additional evidence that certain kind of drug use went up during this period. Fentanyl use markedly increased, and these are sort of gender on the left and age on the right. You can see the green is before and the purple is during the COVID, and you can see sort of the numbers of fentanyl went up at every age group and at every sex, particularly younger folks and males. Another example, sort of reemphasizing the same thing. There is a syringe exchange program, Prevention Point Pittsburgh, and I just got this data from them. And you can see it's a little bit hard to see the exact numbers, but the number of in the graph on the left is the number of syringes distributed weekly, and you can see from 2010 to 2018, sort of going up slowly, and then like through 2020, the number basically skyrocketed, almost doubled, went from 11,000 to 19,000. So pretty incredible. And the number of doses of Narcan or naloxone distributed quarterly, you can see in the graph on the right, also went markedly up between, let me see if, I don't know if you can see this, but this is 2019 here, and this is sort of January to March, and then all of a sudden, this enormous increase. So many, many people received naloxone. Almost 1,000 people received naloxone for the first time in 2020. So really just very high need in the substance using population. Other data that we have, I just continue to press the same thing. This was looking at ED presentations from March to June 2019 to 2020. And what you can see on the left is the 2019 data where myocardial infarction presentations went down. And in the same period, non-fatal opioid overdose went up 2.5-fold. And the number of ED visits went down overall between year to year. So just really showing this incredible issue. Another, same thing, overdoses in Kentucky went up with, a segmented regression analysis, again, over and over, looking at this, seeing this. So why is this, you might ask? So really the reasons for overdose, first of all, social distancing. When you are using potent drugs alone, no one is there to give you Narcan or call 911 or give you rescue breathing. The second was, as we've heard, the supply chain has disrupted, a lot of things that we've been wanting to buy, and our whole economy. There was also disruptions in supply chain for drugs. So individuals may have had to purchase from an unknown source. There may have been more fentanyl mixing. There are a lot of early release from incarcerations, and folks who may have had substance use and were really vulnerable because their tolerance had gone down may have gone back to use. Substance use treatment programs were decreasing access. And I'll talk about that in a minute around access, but very hard to do new intakes. and a lot of programs were shut down for periods of time. There's some data which I'll show on the next slide around mental health and COVID fears. So this is a study, this is a longitudinal study that had been in 2019, and then they also surveyed in June of 2020 of 5,400 Americans aged greater than 18. And what they found was that 25% reported anxiety, 24% depression, 30% anxiety or depression, 36% had some sort of trauma or stress related disorder, like sort of qualifying for the symptoms of PTSD. And then 13.3% started using substances to cope with some of their symptoms. So granted, not as high as some of the other issues, but certainly if 13% of the folks surveyed started to use substance, that's pretty incredible. And then 11% considered suicide in the last 30 days. So all of us know that there is really a major mental health crisis that started a year ago and is continuing on to this day. Burnout, and I'm sure I don't have to tell you, I'm sure you're struggling at WashU with the same things we're struggling at UPMC around, staff, hard to hire staff, people leaving, those who are left standing being burnt out. So, really everywhere there is stress. And then this is a study, and I'm sorry, I forgot to put the reference here, and I can add that later, was an interesting study looking at worry, COVID worry and COVID fear. And this is MTurk. I don't know if you know about that. That's this sort of Amazon online study platform, which is pretty well respected. And they had 160 participants, and they had a combination of new substance initiators during the pandemic, pre-COVID opioid users, and then folks who never used. And what they found was that those who were the newest initiator had the highest COVID worry and fear of substances, except interestingly, opioids. And one of the explanations they gave was potentially opioids was treating that. And so they actually it's like proximally does actually treat fear and worry. And a lot of people say it treats depression, but we're not going to be using that for depression. And when I say people, I mean individuals who are opioid users. And then you look at the pre-COVID opioid users, and they were the ones who had the highest level of worry and fear around COVID. So I do think there is just this intersection of worry, fear, depression, difficulty coping that has led to increase of substance initiation. And another point to think about is this was actually a 2017 article in the Journal of Health Economics. And as the county employment rate increases by 1 percentage point, the opioid death rate per 100,000 rises by 0.19, which is 3.6%. And the opioid overdose ED visit rate per 100,000 increases by 0.95 or 7%. So one of the explanations, and I don't exactly know how that is the mechanism of this, but we do know that these macroeconomic shocks have really also contributed to the opioid death rates. And this, at a state level, a county level, these relationships continue to hold. And the last section I want to talk about is expanded treatment access. In March of 2020, SAMHSA, which is Substance Use Mental Health Service Administration, is the group that puts out the regulations around buprenorphine and methadone as sort of the federal regulations. And so March of 2020, March 20th, they said, well, you can allow a video visit for new patients started prescribing buprenorphine, because previously they said it had to be face-to-face, in person. And then a week later, they said, well, we're not only just going to allow video visits, we're going to allow telephone only encounters for a new start, because they were realizing that this was a major barrier. And a lot of folks who use substances may not have had a smartphone or the ability to do a video visit. So that changed the ability to do telemedicine. And then methadone, as I mentioned earlier, multiple times, there's very strict regulations. And for example, prior to COVID, the regulations were that for the first 90 days, the individual on methadone was not allowed to have any take-home doses, except if the clinic was open 6 days a week, they would have that 1 day of take-home dose. And it took and then after 90 days, you could have 1 day a week. And it was really a year until you could have more than a couple days a week to be on methadone. So really very, very strict, people congregating, coming together. And there's a real fear of increase in COVID based on spreading, based on people congregating to receive their methadone dose. And so the rules were markedly changed for this. So let me just talk a little bit around telemedicine for a second with buprenorphine. So buprenorphine is often office-based treatment. And so by doing telemedicine, it really decreases the transportation barriers and costs for the patients. An interesting thing is somebody who does telemedicine with my patients on buprenorphine, I get to see them in their home environment. It's also really weird. Patients are lighting up their cigarettes when they're smoking to me, which, you know, it's a little shocker at first. I am able, and we're able to have very frequent visits because of telemedicine. And there's a much wider catchment area for patients. There's a lot of programs going on now where starting patients with telemedicine, telebup, has increased capacity. Some of the disadvantages are not all patients have smartphones that have minutes. There's privacy issues. It's complex technology. Urine drug screen monitoring might be limited in this way. And of course, injectable medications need to be given in the office. This is some data looking at the weekly averages of individuals with filled prescriptions before and during the COVID disease 2019 pandemic. All right, so let me orient you. It's a little bit complicated here, and the slide is not as clear as I would like it to be. What you see here is a timeline. So there's the x-axis starts in May of 2019, going through June of 2020. And this dotted line here is the sort of where they're considering the pandemic. So mid-March 2020. And then the black line, the black dots are on the top graph is buprenorphine, and the blue dots are actually all drugs. So cardiac, hypertension, and all the other medications. And what you see here is that the blue line had a steadily increased increased number of drugs, number of individuals receiving medications. And after the pandemic, it goes down because people are not going to the doctor, they're not going to fill their prescriptions. But actually, the buprenorphine numbers stayed the same. And I attribute that largely to the telemedicine changes that those of us who do this work, were able to continue to see our patients. So pretty impressive information. And then, whoops, sorry, I flip this forward here. And then on the bottom, the other thing you see is looking at payers. And so those on Medicaid really had a continued steady increase. Those on commercial sort of leveled off. Those paying cash went down, and those on Medicare kind of stayed the same. And then I'm in a group and we're doing a similar examination, but we now have data going out much further. And the blue line on the top is Medicaid, and the filled milligrams of buprenorphine by payer per individual you could see starting to really increase. So a lot more folks on Medicaid are getting on buprenorphine. These are third-party payers, commercial, which goes down. A lot of people lost their job, they lost their insurance. And then at the bottom, you see the cash, people paying for cash goes down, and then Medicare kind of staying on the same trajectory. So again, this is data that should not be quoted. Haven't published this yet. We're still finalizing the analysis, but just sort of reinforcing the sort of social determinants of health issues. All right, just about done here. The question was, what about these regulation changes in methadone, where people are having more take homes? It's really hard to analyze this, I have to say. But there was one study by a colleague in Minnesota, Kevin Bart, and they looked at their urine drug screens and what the results were. So clearly in 2020, compared to 2019, there were many more positive drug tests for opiates, benzos, methamphetamine, and more that were negative for methadone, which obviously if they're not taking their methadone, it's negative. So, and you could see just an example, 14% opiate positive in July of 2019 versus 22% in 2020. So really different. But then if you try to dig deeper in the data, the folks who had the fewest take-home doses, so this would be people who are most closely scrutinized, they actually did better in 2019 than they did better in 2020 than they did in 2019. The people who had the most takeouts, so these are people who'd been stable, really did the same as they did in 2019. And then the group that really did the worst was those who had sort of moderate number of take-home doses. So maybe they were seen once a week or something like that. So very interesting data. I don't think the jury is out yet on this. So this is my last points here. Just reminding you what we talked about, that this balance between therapeutic use and addiction has been going on for a few centuries now. We know that medication treatments, evidence-based medication, saves lives, improves mortality. Opioid use disorder increased the risk for and worsens the outcomes in COVID, and the opioid use disorder and outcomes appear much worse in COVID than previously, and that we have some regulatory changes in medication that may improve access if they stay long-term after the pandemic is over. Thank you very much. Would love to hear from you on Twitter or email, and I am going to stop sharing now.
Perfect. Dr. Liebschutz, thank you so much for that great talk and for being with us here today. Let me share my screen just so folks can get their credit for being here. And then I will pose some questions to you. First one I see here is from Dr. Barrett. He says, please comment on how opioid use for non-cancer chronic pain became the standard of care in the early 2000s, even among physicians with no contact from drug reps. For example, education from major guidelines and organizations. How were we so badly misled?
So I was among the people who were felt that there was, that patients were benefiting from opioids, and there are patients who do benefit from opioids, but we've had really a consistent increase in substance use over time. And sorry, I'm not being very articulate. Let me think for a second. So I think that opioids treat a whole bunch of different symptoms in addition to pain, not just physical pain, but psychic pain. And it made people feel better. It made people feel less depressed. And so we ended up sort of feeling like we wanted to treat pain. And pain is really important to treat. It's just that opioids are not that effective to treat it. And so, but all of us felt that, opioids were the pinnacle. Look at the World Health Organization scale for pain, and you put, non-steroidals in the first level, but non-steroidals are actually fantastic pain meds, and you put opioids at the top. And so we all think opioids are the strongest pain meds, that should be the best thing for treating pain. So I think that over time we realized that they're not as strong, and not all pain is opioid sensitive. So, yeah. There was a question, I think, about suicide there.
Yeah, I can read several in here. It's just can you comment on the interaction between suicide and opioid use? That blue collar populations like construction workers, they have very high rates of OUD and opioid overdose and high rates of suicide.
So I think I think this is well beyond medicine. I think this is sociological and political. I think our country, the fabric of our country, and the way people interact, and the institutions like houses of worship have deteriorated. And I think it's a very lonely, sad country, and we have not figured out how to overcome some of those barriers where people feel like the answer is taking their life. So I think it's just a really, really important question. And I guess I would throw a challenge to each of you that you each try to connect with your peers, your staff, your patients. Like, connection is the antidote to addiction. And so I would just throw out that we just need to connect as people.
Thank you for that. I'll point out to everyone there's an important comment from Dr. Galati in the chat. You can just read that on your own about how we can manage some of this in an inpatient setting. We've got another question here who said, in surveys of substance treatment centers, only a third offer medications for OUD. And among patients who attend treatment centers for OUD that prescribe medications, only a third receive medications for treatment. It is estimated that only about 10% of patients in treatment for OUD receive medications. So how can we better implement medication treatment for this?
So I'm going to say that when you build something, you build it, it turns out exactly how you build it. So the way we finance treatment dictates how we build it. And so if we were able to incentivize treatment programs and pay them for offering medication, we would probably see more medication. But right now they get paid for different things. And so if you're not paying for it and you're not requiring it, it's not going to happen. So that's kind of what I would say. I also am going to say something, which is, detox. And I didn't talk about it because I didn't have time, but detox is really harmful, and it can cause more overdoses after people leave detox for opioid use disorder. Detox is important for alcohol. And I'm not saying that we shouldn't detoxify patients on opioids, but sending them to a 5-day detox is only going to decrease their tolerance. And when they leave, make them more at risk when they use to die.
And I suppose maybe the last question here, our trainees, at least I should say, our medical trainees are not currently allowed to prescribe buprenorphine or Suboxone, even if they get the waiver. Is that the case at UPMC, or your trainees allowed to do that? And what's your experience been with that?
So that is a federal regulation. If you don't have a full DEA license, you cannot write for buprenorphine.
Yeah, sorry, to clarify, for those that have gotten their own DEA license.
Oh, so they can do it. I think you want to have systems in place though, because residents, I don't know how it is at WashU, but at different places they're 4 weeks on, 4 weeks off, and it's difficult to treat a patient if you're not available, but I don't think there's a reason, and maybe I'll throw this out as a challenge. It looks like on the talk, there's a number of folks who have a lot of expertise in this, maybe setting up a program where you can have residents as a second clinic or something, or with a preceptor who is a buprenorphine prescriber, dually care for patients. I think very, very important. At a lot of places at Pitt, all of the, let's say undergrads, that's not the right word, all of the medical students are getting trained to get their waiver, their 8 hours of training, so that when they do come out, they will be able to be, prescribers. So, yeah.
Wonderful. With that, I guess we'll probably call it for today and just say thank you again so much for joining us for this important topic and your talk. We really appreciate it.
I hope next time to come in person, because I've never been to St. Louis and I want to see that arch. So,
we would love that. We would love that. Thank you,
right.
Dr. Liebschutz, and thank you, everyone. Have a great day.
Bye-bye.